You're going to see a very much an individualized approach to managing congenital TTP patients. And I think this is a function of both the physician as well as the patient. Their ADAM-TS13 activities may give some guidance. They're really going to confirm that diagnosis. It's going to be what's available to the patient. Are they going to have access to recombinant ADAM-TS13? Or are they going to be using a plasma product or a factor VIII concentrate? You're going to talk about patient preferences in the context of what the physician believes. So the physician may believe weekly plasma therapy is required to achieve an ADAM-TS13 level that you need to prevent short-term symptoms or maybe long-term complications. But will the patient be willing to do that if they don't feel that direct benefit today? It's going to be a function of their comorbidities, other issues that they're dealing with, especially cardiovascular complications that may play into their risk for long-term complications. Age is very important, and certainly younger patients may not be on board necessarily with what they're going to be like in 30 to 40 years from now. And younger patients generally have a shorter time frame looking at things, whereas older patients may have life experience, dealt with the medical system, and are more willing and more wanting to prevent these complications since they've had to deal with some of them already. Quality of life considerations are important when you need plasma infusion regularly. And adverse events that they experience with their prior therapies are certainly going to temper their view on how they go forward. So somebody with frequent and severe plasma reactions is going to not be so excited about decreasing the frequency to every week or increasing the frequency as it may be for weekly infusions. You've heard this from Marie already, the ADAM-TS13 activity that you can achieve with recombinant compared to plasma-based therapies, plasma infusion. And it's roughly a five-fold greater time period that you're going to be over an ADAM-TS13 activity of 10% with recombinant compared to plasma. So it very much is difficult to really recommend, 10-day weekly plasma-based therapy, knowing that you really don't have that great achievement of the ADAM-TS13 activity that you're looking for. But as you can see with the recombinant ADAM-TS13, there's a greater time to being over 10%. It's a threshold, really has been extrapolated from immune-mediated TTP that we believe is required to prevent acute episodes. And again, preventing acute episodes is sort of the low bar that we want to get over. These arguments are going to change when we understand better the levels of ADAM-TS13 that we need to prevent subacute symptoms as well as long-term complications.